This is the Pick Your Poison podcast. I'm your host, Dr. JP, and I'm here to share my passion for poisons in this interactive show. Will our patients survive this podcast? It's up to you and the choices you make. Our episode today is called Sudden Death. Want to know what toxin was used by Nazis and is treated with vitamins? Is potent enough to kill a moose in 20 minutes? A poison where the antidote changes the color of your blood and skin? Listen to find out. Today's episode starts in the emergency department. You're sitting at your desk, taking advantage of a momentary lull to sign some charts and eat a granola bar, when the charge nurse shouts for help. Not his usual, "Doctor, room 1 now," but a panicked shout. He's been an ER nurse for 20 years. He doesn't panic, not ever, not for any reason. You jump up and run over. One of the other nurses collapsed in the nurse's station. She's on the floor unconscious. You check for a pulse. It's weak and thready, but present. And you help her get into a room, expecting her to be awake by the time you get there. Syncope, the medical word for passing out, is extremely common. It's often from standing too long, not having enough to eat, or dehydration. The team hooks her up to the monitor to get vital signs. You ask the charge nurse what happened. He says the patient was sitting at her computer and drinking a protein shake while calling report on a patient being admitted upstairs. She hung up the phone, said she didn't feel good, was dizzy, and had a headache. He says she was pale, sweaty, and looked terrible. He says, "I told her to take a break and go rest in the back. She was too weak to stand up, so I went to get the blood pressure machine, and then she just collapsed to the ground. According to the patient's chart, she has no medical problems and doesn't take any medicines." A nurse reads out the vital signs: temperature 98.5 or 37 Celsius, pulse 44 beats per minute, respiratory rate 8, and oxygen saturation is 90% on room air. And the blood pressure, the nurse hesitates, frowning at the monitor. It's reading 50/30, probably an error. She hits a button on the machine to recycle the cuff to see if it's a real measurement. On exam, the patient is unconscious, not even responding to pain. Her pupils are normal. She's breathing, but with a shallow effort. Her heart is slow, but otherwise normal, and her lungs are clear. The nurse calls out the repeat blood pressure, 54/29. Uh-oh, this does not look like a simple case. Vasovagal syncope is a common cause of passing out, caused by standing for too long, not eating enough, or being too hot. It's probably happened to you or somebody you know, and it's not life-threatening unless you're driving. Typically, it resolves on its own, which is exactly what's not happening here. As usual, we start with the ABCs. The nurse puts an oxygen mask on with 100% oxygen, improving her saturation to 94%. The airway and breathing are tenuous, but okay for now. C, for circulation, is the immediate issue. The nurses are working on IV access, and you order 2 liters of normal saline to improve her blood pressure. It's pretty odd that her heart rate is this low. An otherwise healthy person with a low blood pressure should compensate with a rapid heart rate in an attempt to increase cardiac output, i.e. blood flow. Is this perhaps a primary heart problem causing the low heart rate? Well, it's not impossible, though it's pretty unlikely. I mean, otherwise healthy 30-year-olds don't suddenly need pacemakers out of the blue. In prior episodes, we've discussed medicines causing low heart rate and blood pressure. Possible, but per the chart at least, she's not taking any medicine. There are way more questions here than there are answers. You force yourself to focus on resuscitation first. The nurses are having trouble with IV access. The resident grabs a central line kit and gowns up. A central line is a very large catheter placed into a vein in the neck, chest, or the groin. He asks you to hold the ultrasound probe so he can visualize the vein, pops the catheter in, and starts drawing blood. He stops and holds up the first tube, saying, "I think I put the line in the wrong place." The tube is filled with bright red blood. Question number 1, what does he mean? A, he hit a nerve. B, he caused internal bleeding. C, he hit and collapsed the patient's lung. Or D, he put the catheter in the artery instead of the vein. The answer is D. He's questioning if he put the catheter in the artery instead of the vein. Arterial and venous blood aren't the same color. Arterial blood is oxygenated and therefore bright red. Venous blood is deoxygenated after circulating through the tissues, and it's typically dark red. The tube he's holding up does look arterial. Central lines are supposed to be venous because arterial lines are too risky, and if so, we need to remove it and try again. He repositions the ultrasound probe, and you both look at it from several angles. The catheter is in the vein where it belongs. You reassure him and use the catheter to infuse the fluids as rapidly as possible. A tech hands you the EKG. It shows a slow heart rate, but nothing else. No heart attack, no abnormal intervals, including the QRS and QTC intervals. The radiology tech shoots a portable chest x-ray, also normal. And despite the 2 liters of IV fluid, her blood pressure doesn't improve, and in fact, her heart rate is getting worse. It's now in the 30s. You order norepinephrine, a strong vasopressor, in the hopes it will increase both her heart rate and her blood pressure. The vital signs respond mildly. Her heart rate goes up to the 50s and her systolic pressure to the 90s. You make a risky decision to send her for a CT scan. It's every emergency medicine physician's worst nightmare to have a cardiac arrest in the radiology department, but we have no idea what's happened to our nurse and we need answers. You send the resident down with her, telling him to scan her head and if she's stable enough, her chest and abdomen as well. What are we looking for? Anything we can get. This is basically a Hail Mary. Spontaneous rupture of an aneurysm with resulting intracranial hemorrhage is possible. She did say she had a headache, though immediate cardiovascular collapse isn't that likely. A ruptured aortic aneurysm or an aortic dissection can certainly cause immediate cardiovascular collapse, but in a healthy 30-year-old, not likely. A pulmonary embolus might cause it, but again, you'd expect her to have some shortness of breath or chest pain prior. Back at your desk, you run your fingers through your hair, hoping not to hear a code call to radiology. What the heck has happened to our nurse, and what the heck should we do next? It's never a good feeling when you don't know what's happened to the patient dying in front of you. It's worse when the patient was otherwise healthy, and it's 1 million times worse when it's someone you know. The images come across from radiology. You scan through. You're no radiologist, but you don't see anything catastrophically wrong. That's good news and bad news both at the same time. The resident brings her back safely to the emergency department. It's really difficult to generate a differential diagnosis when you're in the midst of a life and death struggle trying to resuscitate a patient, but you do have to give some attention to what might have happened to determine what might help. This is sudden cardiac death, essentially, though we're doing our best to avoid the death part. A lethal arrhythmia would be diagnoses numbers 1 through 10 on my list, but unlike an out-of-hospital arrest, we had her on the monitor almost immediately, and we would have seen if she had ventricular fibrillation or ventricular tachycardia. She didn't. A pulmonary embolus, as I mentioned earlier, can cause it, but the radiologist officially reports all of her scans are normal, meaning no blood clot. Things like long QT syndrome from either congenital or acquired causes like drugs are possible, but again, the EKG was normal and no VFib or VTAC. Myocarditis, infection in the heart, and valvular disease is on the list, but again, she should have had some symptoms prior to collapsing. Certainly we'll need an echocardiogram to take a closer look at her heart, but this isn't a cardiology podcast, it's a toxicology podcast. So what about toxins causing sudden cardiac death? We've discussed some of these on prior episodes. Many medicines causing long QT, as I've mentioned, but we've ruled that out. Same with sodium channel blockers causing QRS prolongation. Aconitine is great for sudden death. See the toxic T episode. But it just doesn't quite fit here. What about toxins causing a slow heart rate? Yes, beta blockers and calcium channel blockers could fit, but they don't cause this dramatic collapse. She'd have symptoms over at least an hour, if not many hours. Same with imidazolines. We previously talked about Visine eye drops, mistakenly said to cause diarrhea in the movie The Wedding Crashers, but really causing an altered mental status, low blood pressure, and heart rate. So while her symptoms fit there, the sudden onset just doesn't make sense. Sudden sniffing death would be great, but she wasn't sniffing glue in the middle of the emergency department, and again, no VTAC. I really don't love this list, and we could go on, but the bottom line is she needs an ICU bed. The nurse tells you she's maxed out on the norepinephrine. The initial improvement in the patient's vital signs were transient, and her heart rate and blood pressure are now coming back down. You order a second pressor, and minutes later, the patient loses her pulse and codes. You call CT surgery for ECMO, extracorporeal membrane oxygenation. After several rounds of epi and CPR, she gets a pulse back, though I wouldn't be optimistic it'll stay that way. The CT surgery fellow inserts 2 huge catheters, one arterial and one venous, for the machine to oxygenate and pump her blood for her. You see him frowning as he discusses arterial versus venous access with his nurse practitioner. The patient's labs result, all normal except an extremely high lactate at 12. A normal lactate is 1. You click past it, you've already covered her with antibiotics in case of infection, and an elevated lactate is common in shock and cardiac arrest. Except she didn't have a long downtime like out-of-hospital patients. You click back. Question number 2. There are 2 clues here as to what might be poisoning our patient. What are they? A, the elevated lactate. B, the bright red venous blood. C, the low heart rate. D, the low blood pressure. The answers are A and B. The clues are the lactate and the bright red blood. Now, obviously, the low heart rate and the low blood pressure are significant and life-threatening. But in this case, they're the result of exposure to the toxin rather than the real clues. The elevated lactate in the bright red blood can go along with a certain toxin causing cardiovascular collapse. It's time to pick your poison, and that's question number 3. What is poisoning our patient? A. Arsenic, B. Carbon monoxide, C. Cyanide, D. Chloral hydrate. The answer is C. This is very worrisome for cyanide toxicity. Now, red blood and an elevated lactate do go along with cyanide. They are not, however, completely diagnostic. But cyanide does cause sudden cardiovascular collapse and the symptoms our patient is having. Carbon monoxide can cause cherry red skin, though this is rarely seen and mostly observed post-mortem. Carbon monoxide definitely fits, but if she were poisoned, you and the rest of the nurses would be sick or dead. Arsenic is very lethal, but she'd have had some preceding symptoms like GI complaints. Chloral hydrate, which is the ingredient often in a Mickey Finn, causes sedation and rapid onset of symptoms, but not really profound bradycardia and hypotension like she has. Cyanide? What do we do now? Is there an antidote? That's question number 4. The antidote for cyanide toxicity is A. Hydroxycobalamin, vitamin B12, B. Narcan or naloxone, C. Prussian blue, or D. vitamin K. The answer is A. Hydroxycobalamin, vitamin B12. Naloxone is obviously for opioid overdoses, Prussian blue for thallium or radioactive cesium poisoning, and vitamin K reverses some anticoagulants like warfarin or Coumadin. We actually have several antidotes for cyanide, believe it or not. Currently, we use B12. There's an old cyanide antidote kit, which you might still find in some emergency departments, which consists of 3 parts. Amyl nitrate is the first part. It's in a vial like smelling salts to use before IV access was obtained. These were always missing from every kit because they themselves can be a drug of abuse. They're called poppers. The second step was sodium nitrate, and the third step, sodium thiosulfate. So should we treat our patient, or should we wait to confirm the diagnosis? The answer, if you're even considering cyanide, treat immediately for 2 reasons. First, cyanide is rapidly lethal. There's no time to wait. And the second is that testing will take days, if not longer. You order the cyano kit with B12 and the nurse starts it immediately. How does it work? Basically, it binds up and inactivates the cyanide. Hydroxycobalamin is a very big molecule, and when it binds cyanide, it becomes cyanocobalamin, with the cyanide essentially sequestered inside. B12, it's a vitamin, so you can imagine it's very safe. But the antidote does have one big side effect. It turns everything bright red, much more so than the cyanide will turn the venous blood. The patient's skin, secretions, and urine are red, which isn't harmful. It also turns their blood red, which is not harmful either, but does interfere with lab testing, much of which is colorimetric. So you have to anticipate you're going to get a lot of spurious lab results after you give the B12. How does cyanide poison you? It causes complete energy failure by disrupting oxidative phosphorylation and energy production. It interferes with the electron transport chain, causing hypoxia or a lack of oxygen at the cellular level. This lack of oxygen results in failure of normal aerobic metabolism and in turn the elevated lactate. And it's also the reason the venous blood is red because the cells can't extract and utilize oxygen as they normally would. Both our resident and the CT surgery fellow initially suspected mistaken line placement when the venous blood looked arterial. Cyanide exposure is lethal via many routes, including ingestion and inhalation. As usual, I'm leaving out details in case anyone with nefarious intent is listening. Symptom onset can be as quickly as seconds after exposure to cyanide gas or minutes after ingestion or injection. Patients might complain of a headache, anxiety, agitation. They can become confused and lethargic, progressing to, you guessed it, seizure, coma, and death. Cyanide is used in a lot of industries, including electroplating of jewelry. It's used in mining and plastic manufacture, just to name a few. It's used as a pesticide. In New Zealand, it's used to poison possums, which are a danger to cows because they transmit bovine tuberculosis, interestingly enough. Cyanide occurs naturally as amygdalin in things like peach and cherry pits and in bitter almonds. You can actually buy dried cherry pits in health food stores. It's shocking to me, and people have actually unintentionally poisoned themselves by eating these, so please do not eat them. Outside the US, amygdalin is marketed as Latril, a supposed anti-cancer agent, which not only doesn't work, but causes cyanide toxicity and has killed patients. I mentioned pesticides, but animals can also die of naturally occurring cyanide. Seeds and leaves from choke cherries, for example, are toxic in small amounts. Eating less than 1% of their body weight is enough to be lethal to an animal. Even a huge animal like a moose, which can be 6 feet tall and weigh as much as 450 kilos or 1,000 pounds, can die in as little as 20 minutes after exposure to choke cherries. Interestingly enough, naturally occurring cyanogenic glycosides are mostly poisonous to animals with rumens because the glycosides are hydrolyzed inside the rumen to free hydrogen cyanide. Hydrogen cyanide was used in World War I, though in the open air it dispersed pretty quickly rather than causing much toxicity, fortunately. It's been used in both murder and suicide. The Nazis used it to kill millions in the gas chambers. They used it to kill themselves. Hitler and Eva Braun both took cyanide. Hitler then shot himself thereafter. Himmler and Göring committed suicide with cyanide after they were captured by the Allies. Jim Jones put cyanide in the Kool-Aid at Jonestown, where more than 900 people died of cyanide toxicity. There is very dramatic footage of Bosnian Slobodan Praljak ingesting cyanide and committing suicide in The Hague immediately after his conviction for war crimes. Question number 5. Cyanide was used to poison which medicine, killing 7 people in Chicago in 1982? A. Motrin, B. Tylenol, C. Cough syrup, or D. Tums? The answer is B. Tylenol, and these murders are still unsolved after an unknown person poisoned Tylenol bottles with cyanide. The manufacturers, Johnson & Johnson, introduced tamper-proof packing, which is now standard practice industry-wide. So back to our patient. Her heart rate and blood pressure improve after 5 milligrams of hydroxycobalamin. She's now in the ICU, and you recommend a second dose, hoping the antidote will be enough to save her life. You send off blood cyanide levels, so the hospital laboratory will have to send it out, and it's unclear how long the results will take. Cyanide toxicity, fortunately, isn't common, but there is one exception where we emergency medicine physicians are always on the lookout for it. This is in fire victims. Many things that burn actually give off cyanide, and any fire victim with an elevated lactate above 10 or other concerning symptoms is treated immediately with B12. Now, of course, the patients might be suffering from smoke inhalation, carbon monoxide toxicity, or other problems, but cyanide is always on our list. A nightclub fire in Brazil resulted in the deaths of 250 people, many of whom died of cyanide toxicity secondary to hydrogen cyanide released from the burning of the soundproofing materials in the walls. So back to our patient. How did she develop cyanide toxicity while at work in the hospital? That is an excellent question. The ICU team calls in law enforcement to investigate. In typical ER fashion, the protein shake is exactly where she left it, in a water bottle next to the computer she was using at the nurse's station. They discover cyanide in the drink, and they discover searches on her husband's computer with phrases like most lethal poisons, undetectable poisons, and how to buy cyanide. She recovers, though slowly, including a long period of rehab. Her husband is eventually convicted of attempted murder after trying to kill her when she said she wanted to leave him. This is a fictional case, as are all our cases to protect the innocent, but it is based on real poisonings. Cyanide, you may remember, was a favorite of Agatha Christie's. It's classically associated with the smell of bitter almonds. If we'd have smelled the protein shake, would we have made the diagnosis quicker? Maybe, but an interesting fact is that only about 40% of people have the gene to allow them to discern the smell. So maybe not. Bitter almonds always makes me think of one of my favorite books. The opening line in Gabriel Garcia Marquez's Love in the Time of Cholera is, quote, "It was inevitable. The scent of bitter almonds always reminded him of the fate of unrequited love," end quote. Anyway, it's time for the last question in the podcast in today's pop culture consult. In the James Bond movie Skyfall, the villain Raul Silva is disfigured with a misshapen face and jaw after reportedly taking a cyanide pill in a suicide attempt. Can a cyanide pill really cause facial disfigurement? A, true. B, false. Follow the Twitter and Instagram feeds, both at PigPoison1 for the answer. Remember, never try anything on this podcast at home or anywhere else. Thanks for listening. It helps if you subscribe, leave reviews, and/or tell your friends. Transcripts are available at pigpoison.com. While I'm a real doctor, this podcast is fictional, meant for entertainment and educational purposes, not medical advice. If you have a medical problem, please see your primary care practitioner. Thank you. Until next time, take care and stay safe.